and understanding of physiology is very important because it will help you out in terms of evaluation, management, and overall pathophysiology in that regards. So today we'll talk about the basics of endocrine physiology. What really is an endocrine gland? What are hormones? How do they act? How do they interact? And in that, we'll also put some case scenarios to really highlight the interaction between physiology and how this physiology helps you identify in terms of pathophysiology. We'll now touch base about embryological aspects. So one unique aspects of different hormone glands is that they also usually have a dual origin. So if we talk about right from pituitary, you have got the anterior pituitary and the posterior pituitary. Anterior pituitary is glandular, posterior pituitary is neural. Then let's come to thyroid. Thyroid gland, you have got the follicular and the parafollicular. Parafollicular again is neural tissue. Adrenal, you've got adrenal cortex and medulla. Cortex is gland and medulla again is the structure which is neural. If you talk about pancreas, you have got the exocrine, endocrine pancreas. Gonads, you have got the cortex or the basic gonads, and then you have which comes from the urogenital tract, while you have got the germ cells which come from outside. So most endocrine glands have a dual origin. And this dual origin has significant implications in terms of a lot of pathophysiological perspective, which we'll discuss about later on. So when we talk about the adrenal, you have got the neural and the glandular tissue. Now, adrenal, of course, is coming from the urogenital ridge, from which the kidneys, the gonads, as well as the adrenals are coming. So that's the area it is coming. And then from there, you have got the adrenal cortex, which produces cortisol, aldosterone, and DHEAs, which are steroids, and the medulla, which produces the catecholamines, which have got a different function, different action in that regards. But still, there will be a synergy. Why do you have impaired catecholamine response, Dr. Vibha, in somebody who is cortisol deficient? Or if I ask you the other way around, why do cortisol deficiency cause hemodynamic instability? Yeah.
Cortisol deficiency. The catecholamines will not be fixed.
So what does cortisol do to the pathway? So you're right. When you have got stress, the blood flow goes up and blood supply such that it goes from the periphery to the center. It will take cortisol inside. But what does cortisol do to the catecholamine? It activates. So this class is more like a revision of everything that you have learned maybe in the last 3 years for everybody. So it's like a revision. So it increases the activity of which enzyme? PNMT. So it is going to cause more conversion into epinephrine, and then it is going to cause that. So it's such a fascinating mechanism that if you want to increase your blood pressure, cortisol has a permissive role as far as BP is concerned. It has a role in free water, but it does not directly increase blood pressure. But why do we call stress hormone? Because when your cortisol goes up, it will increase the blood flow. It will go into the medulla and say, okay, come on, let's get epinephrine. And then it will start working as a stress hormone in that perspective. So this dual region becomes important. Now, why this dual region is also important is that disorders are different. In medulla, you will have neural disorders like pheochromocytoma or paraganglioma, which are like neuroblastomas. While in the cortex, you will have different group, adenomas. So they will, of course, have a different origin. Carcinoma, they will have a different scenario. Different genes will be regulating their disorders as well. The most classical example is, of course, pituitary. And we have discussed already that you have got the neuroectoderm, which is responsible for the neurohypophysis, which is basically a neural tissue. While you have got the glandular tissue, which is coming from below, and the neural tissue which is coming from above. And these two will then join the rat case pouch, and then they will form the anterior and the posterior pituitary. These two are quite distinct in terms of their structure, in terms of their organization, and in terms of their blood flow. So in particular, the neurohypophysis has a separate blood flow as compared to the adenohypophysis. Now, we were discussing yesterday, Ashutosh, about a particular condition, Sheehan syndrome. In Sheehan syndrome, we only have anterior pituitary involvement, while we do not have diabetes insipidus. Why? Yes. So it is basically a postpartum necrosis of the pituitary gland. So what is happening is there during pregnancy, the pituitary becomes bigger and you need a lot of blood flow. Suddenly somebody goes into a hemorrhagic shock. You have got a lot of postpartum hemorrhage. Your blood supply becomes less. So the anterior pituitary is completely necrotized. It is completely destroyed while the posterior pituitary is preserved. So the presence of diabetes insipidus will therefore exclude a vascular injury to the anterior pituitary. So I think that becomes important from that regards. The other important thing that we remember is that neurohypophysis is basically a storage area. It's just a neuron. So neurons are directly coming from there and you're storing your AVP or your oxytocin in that regards. While the adenohypophysis is an active gland. So which of these will be affected more in radiotherapy?
The glandular part is affected.
Yes, so neural part is affected less. So in somebody who has got radiotherapy, you will see growth hormone deficiency as the first manifestation, precocious puberty followed by delayed puberty as second, adrenal insufficiency, thyroid later on, but you will never get diabetes insipidus because of a DI, because of radiation, because you will need huge doses of radiation to burn those cells in that regards. The other very interesting thing when you're talking about anterior and posterior pituitary is that suppose you have got a pituitary lesion. I'm not talking about a vascular insult. Suppose your pituitary is completely destroyed. Still DI doesn't happen. Why? Hmm. So when you have got 100 neurons which are coming from the hypothalamus to the posterior pituitary, some of them are smaller. They say, okay, I don't want to go that much. They are just finishing at median eminence. So even if you remove the pituitary completely, you will have enough neurons to produce vasopressin. So it will preserve your DI to happen. So this understanding of physiology becomes absolutely important from that perspective. So now when you have a pituitary development, you will also have development of other areas as well. So by looking at the child who comes to you with multiple pituitary hormone deficiency, you may say, okay, at what level the problem is. So Dr. Vibha, we have a 1-week-old boy with seizures, has hypoglycemia, which is ketotic, has got low cortisol and low growth hormone. For the level of hypoglycemia, we expect cortisol to be 550, growth hormone above 10. So they are both low. He has micropenis, which finding on examination will tell you that this is something which is very early in terms of embryonic development as compared to late. So something you will see on examination which will give you. Yes. So if you have eye, ear, spine, so if you have a problem in the whole face development, like pituitary, of course, will start from the face development, then you will know, okay, this is a very proximal defect. So here, what we are seeing is that there is a nystagmus or blindness. So what it means is that eye development is also defective. So we are talking mostly about a HESX1 problem, septo-optic dysplasia. So looking at a child, you can say, okay, which level the defect is in that perspective. So this was a HESX1 or septo-optic dysplasia. Now we've talked about the pituitary, we have talked a bit about adrenal, a bit about parathyroid. Now parathyroid is a unique gland. Parathyroid, does it have a dual origin? No, parathyroid is a single origin. But it is actually not a single gland, it has got 4 glands. And it is developed from different branchial pouches from the down growth of that, and then it gets deposited in the gland. So actually, those which are superior parathyroid are actually descending less, so they are actually inferior. So we will have a descent which happens from the parathyroid. The lower one do not descend much, they stay there, while upper one descend and become on the lower side. And with the parathyroid, there is an intrinsic development of thymus. So if you have a child who has got hypoparathyroidism, the first thing, if you have a newborn, let's say, the first thing you should go and have a look is that whether there is an immunodeficiency or not, because you may have a thymic defect. And that can be a very, very dangerous situation. This is a classical situation of DiGeorge syndrome, which can be lethal in that perspective. So 1-week-old boy with seizures, Dr. Dhwani, hypocalcemia and phosphorus is 9.1. So without going into anything else, what are you thinking of? So of course, you will exclude the creatinine renal failure. So that's normal in that perspective. Creatinine is normal. Now, in this perspective, what you're seeing is PTH is low. So you're going into hypoparathyroidism. Now, there is what else you will like to do in this child? Yeah. Yes. So what are you looking at? I'm talking about specific clinical as well as investigational things. Alpin facies for, that is hypercalcemia. That is Williams. So you have to get chest X-ray for the thymus and echo to look at other cardiac defect. Very importantly, look at the CBC. We had a child with DiGeorge syndrome who had got a very low lymphocyte count. And that can be a very, very direct clue that is there that, of course, the lymphocytes are also defective in that regard. So there's an absent thymus. So this was a DiGeorge syndrome, which is there in that regards. Now, what about pancreas? So I discussed already that pancreas is again a combination of exocrine as well as endocrine functions which are there. So you have got three major hormones coming from there, the insulin, the glucagon, and somatostatin. And there are multiple genes which are regulating the pancreatic growth from that regards. So abnormalities in pancreatic development will have different perspective in terms of the type of diabetes that you see as compared to those who have got just the endocrine pattern involved. So 5-month-old boy with failure to thrive, Alapan, there is hyperglycemia, weight is very much low, there is steatorrhea, low fecal elasticity. So what are you looking at here? So pancreatic agenesis may be there. So pancreatic agenesis because of a PDX1 defect or IPF, the insulin promotion factor can be there in that regards. Gonad development again is a very, very interesting process. I said you have got a urogenital ridge, and the urogenital ridge gives rise to the gonad, the adrenals, and the kidneys. So commonly, if you have a defect in the WT1, you have kidney involvement and gonad involvement. That's the Frazier syndrome, the Dennis-Dash syndrome, all those WT1 defects are there. If you have a defect in the NR5A1, you will have the adrenal defect as well as the gonadal defect is there from that perspective. And both of them will then result in development from that perspective, which will result in the NR5A1 and SRY along with SOX9 resulting in a male development of first the Sertoli cell and then from there the AMH, then you have the DHH and finally testosterone. This is a different thing which we'll discuss much later on. But of course, you've got a complicated stepwise processes. So what you need to remember is that when you have an embryonic development, there is often a switch on and a switch off sign. So there are genes which will get activated and those genes will then either switch on some and switch off some. So if you have SRY, you will switch on SOX9. So SRY we talk about is the main determining factor as far as the sex determination is concerned, but the major effect is through SOX9. While if you do not have SRY, you have got anti-testis genes like DAX1, like FOXL2, they're going to work out and that perspective. So this timely regulation of genes becomes also important. Which other gland, you have got a very time phase based maturation of different genes which switch on, switch off, and they will decide about the development. We talked about gonad, pituitary. So in the initial phase, you've got genes which are involved in the craniofacial development, HSX1, LHX3, LHX4. Then you've got ones which will then, the prop1 will come and it will switch off all of them. Because if you allow them to keep on growing, they will have a lot of problems. And then prop1 will start maturing those cells. And from there, you've got the PIT1, PITX1, all the other genes will come. So this transcription factor act like a synchrony. They act like a way in which orchestra like a scenario. So one tone will go up, other will come down. This is how they will work. So 1-month-old child with DSD, TADA4 at birth, palpable gonads, and there is a XY. What are you worried about in terms of the short and long term in particular? Yeah. So XYDSD basically. Okay, that's there. Anything else? Which other organs? So mainly kidneys I'll be really worried about. So was given testosterone and the penile has increased. Everybody was happy, but 5 years later came with renal failure. Because we said that you can have a WT1 defect. This may be a Dennis-Diaz syndrome. This may have the Fraser syndrome. Nobody comes to you with a thing stuck up that I am Dennis-Diaz. So clearly, if you have a XYDSD, understanding the genetics becomes important. If we know that there's a WT1 defect, you know that there's a kidney problem which is going to come up soon.